Hello, everyone. Welcome to today's webinar on the use of selective serotonin reuptake inhibitors in pediatric clinical practice. Glad you're here with us today. Before we get started, a couple of housekeeping items and announcements. For those of you who have not yet heard, we are now named CalMap, same service, new name. And just a quick reminder that we do offer those telephone consultations with our child and adolescent psychiatrists. So if you want personalized guidance as to how do we put this all into practice from this patient that I'm seeing today, this is the number to call. You can also go onto our website and place those consults online through our web portal. And finally, wanting to remind everyone that we do offer the monthly webinars on demand as recordings. So you can go to this website and watch recordings and see any questions in order to get credit. Next slide, please. There are no relevant financial disclosures to share with you today. What you'll see on the slide is just a quick note about our funders, including the Health Resources and Services Administration, as well as the California Department of Healthcare Services. And with that, I would like to introduce our speaker today. We're very fortunate to have Dr. Ryan Rampersaud, who is a child and adolescent psychiatrist in the Division of Child and Adolescent Psychiatry in the UCSF Department of Psychiatry and Behavioral Sciences. He also serves as one of our psychiatric consultants for CalMap. Dr. Rampersaud completed his MD and PhD in microbiology and immunology at Columbia University and his psychiatry residency and child and adolescent fellowship here at UCSF. His research program focuses on the role of the gut microbiome in the development of psychiatric disorders, including mood disorders, and understanding the biological mechanisms by which early life adversity affects physical and mental health. As mentioned earlier, he will be speaking today on SSRIs. As usual, we'll be reserving the last 15 minutes for audience Q&A. So if you have any questions for our speaker, please share these in the Q&A section of the Zoom controls. And with that, pass the virtual mic over to Dr. Rampersaud.
Thank you so much. So really excited to be here with all of you to talk about the use of SSRIs in clinical practice. I think this is a really important topic given the ubiquity of SSRIs and their utility in treating a variety of mental health disorders that we commonly see in the clinic. And so really the goals today are to describe 3 commonly used SSRIs, including their usual amounts as well as dosing, to talk a little bit about risks and common side effects of SSRIs. And then really, I think really critically is for us to develop and apply language pearls for patients and families when we talk about risks, benefits, and side effects. I think this last point is really, really critical. We're always partnering with our families and giving them really great information in a way that is easily digestible and useful for them is really critical in order for us to help these kids and their families. So really excited to talk with you through all of this today. Just really quick background, right? The sort of prevailing mechanism that has driven drug development for many years is this sort of idea of the serotonin hypothesis of depression, and as well as other psychiatric disorders. And in depression in particular, there seems to be this sort of depletion of serotonin. And the idea is that SSRIs are meant to restore this balance, and that balance may be dysregulated in depression and anxiety, things like PTSD, and other psychiatric disorders that we commonly use SSRIs for. They block the presynaptic reuptake inhibitor, and they can treat both depressive and anxiety symptoms. As you'll see, right, we use it in major depressive disorder, anxiety disorders, and in some cases, PTSD as well. So understanding these drugs and how we use them and when to deploy them is really critical in our practice, especially given the current trajectory of things where mental health issues are becoming much more apparent and much more commonplace in the youths that we treat on a regular basis. I show this just to demonstrate that over the course of several decades, the prescribing of psychotropic medications has significantly increased over the years. And you can sort of see right here in the middle um, antidepressant use has increased significantly. And again, this may be reflective of the sort of increasing prevalence of psychiatric disorders in the youths that we're seeing. Um, Want to just make mention again across this is not just a US phenomenon, but this has been happening in other countries across the world. Netherlands, the UK, again, prescribing has consistently increased. We will talk a little bit about the black box warning for suicidal thoughts with the use of SSRIs a little bit later. And that did cause a slight dip in the prescribing, but over time that has gone back and continued to increase, again, reflecting really the burden of mental health issues that are affecting all of the youth that we see in our practices. And so when we talk about um, optimal treatment and how we go about taking care of these kids using SSRIs, we really want to sort of define a few things, a few sort of terms: so response, remission, recovery, relapse, and recurrence. And these are just sort of helpful in thinking about where am I at in terms of the use of an SSRI with my patient. And so response just refers to no symptoms or significant reduction in symptoms for at least 2 weeks. Remission is, again, no or few symptoms between 2 weeks and 2 months. And recovery is an absence of symptoms for more than 2 months. Relapse is an episode during the period of remission. So in that period between 2 weeks and 2 months where symptoms kind of do an uptick again. And then recurrence, an emergence of a new episode, right? During the period of recovery. So after that 2 month period. When we think about treating kids with SSRIs, do think that it's helpful to think in 3 phases and kind of reorient ourselves as to where we are. First phase is that acute phase, and really our goal there is to achieve the response and achieve full symptomatic remission. After being in the acute phase, right, which can take any number of trials and any amount of time, we then want to move into that, think about we're being in this continuation phase. We want to consolidate the response to treatment and avoid relapses. This doesn't only include continuing medications, but also thinking about supports, environmental supports, and other contextual factors that might actually be helpful. And then maintenance, again, avoiding recurrence and new responses. So episodes rather. And so in this phase of our treatment, we're really thinking about, okay, we've moved into this recovery place. How do we prevent a new episode from occurring? And again, thinking in a very long-term way about how we bolster the resilience of our patients and how we change or shift environmental or contextual factors to help them really be successful in preventing another recurrence or the development of another episode of their psychiatric disorder. Really, really critical, right? Want to be thinking about if you're thinking there's a depressive component, thinking about ruling out anxiety, or if there's an anxiety disorder, thinking about non-psychiatric reasons for having a anxiety presentation. And you can sort of see on the side, there's this kind of great acronym, Think Me. So that includes tumors, things like pheochromocytomas, which produce lots of adrenaline, hormones. So hyperthyroidism may present as an anxiety disorder. Infections like fever, strep, Lyme disease. Thinking about nutrition, vitamin B12, hypoglycemia, eating disorders, right? C stands for central nervous system and cardiac. So things like migraines or head trauma could potentially be contributing to an anxiety presentation. And then M is sort of the miscellaneous kind of other things that maybe masquerading as an anxiety issue, like Wilson's disease, asthma, Addison's disease, or Cushing's disease. And then lastly, E, electrolyte imbalance, environmental toxins. And then the other thing that we really want to be thinking about is substances. Especially with our adolescents, we want to be thinking about, is the presentation of an anxiety disorder in our kids due to some underlying factor like use of an illicit substance? And in that case, really, right, going the route of an SSRI is not necessarily the first step that we want to do. We really want to remove anything that might be contributing, reassess, and see if those symptoms persist, right? There may also be an underlying psychiatric disorder present, but removing these sort of medical or organic causes of anxiety will be really critical. And the same also applies to depressive presentation. So if you have a kid who is presenting with depressive symptoms, again, really, really sort of thinking about those organic causes before we jump to an SSRI. So things like anemia, hypothyroidism, right? Maybe you've had a kid who is playing a sport and has suffered a concussion. We really do want to think about that. Autoimmune or chronic fatigue syndrome, things like cancer, again, nutritional deficiencies like a B12, or pregnancy in our kids who are of that age. And again, substances are always on the differential and really want to be asking in a really significant way and direct way about the use of things like that, just to make sure we're not missing anything. And so well, how do we do this? Somebody comes in, how do I know what's going on? And I probably don't have to tell this audience, but screens and tools are really fantastic. It takes the guesswork out of it. Kids can do it either by themselves, or it can be parent report. And oftentimes, because it's not under supervision or in the presence of a provider, right? Kids can sort of fill this out in the comfort of their own home or on their device, where maybe they feel a little bit safer, kind of giving up pieces of information about how they may be feeling or the things that they are struggling with. And so, again, for anxiety, things like the GAD-7 and the SCARED, fantastic to use. GAD-7 is great because it's short. Depression, the PHQ-2 and the PHQ-9, and for younger kids, the short mood and feelings questionnaire. And then the RCADS is more of a research tool and is long, but in some cases, if you have the time and you really wanted to dig into symptoms and have a kind of blueprint or a roadmap, that could be helpful for you to just have in front of you if you're having a conversation with somebody. So think about taking a look at that at some point, and seeing how it may fit into your practice. Again, not useful from the perspective of like a rapid screen like the PHQ-9 or the GAD-7, but lots of useful information for you to potentially use in your conversations with kids. So a few general guidelines, right? Because what do we do when somebody comes in and we think that they need an SSRI? So one of the big questions that we often get is there a difference between in terms of efficacy between different SSRIs? And the reality is that as far as we can tell, they look pretty similar. It can often feel like a trial and error kind of experience, and unfortunately, that may be the case. One medication may work and another one may not, and you may have to cycle through one or two before you get there. Um, but some factors that might help you decide or reduce the number of trials you have to have is one, past response history. So if they've been on something before that worked, or if they had a parent or a family member who had previously tried a medication, that can be a great guiding principle. Side effect profiles. So, if you're worried about being overly sedated or increasing anxiety, there may be some particular choices, and we'll talk about that in a minute. And then coexisting medical conditions. So, if you have a kid who's medically complex and maybe is taking lots of medications, escitalopram, for example, can be a useful one because of its low interaction effect. Um, Another really main general point is 3 to 6 weeks between therapeutic dose and symptom improvement. And some remission is usually seen by week 4. So what we mean by that is just to say, setting expectations with your patients that this takes some time, and let's reevaluate once we've made a dose change in 3 to 6 weeks to see if we've actually moved the needle on the symptoms that you're experiencing. If there's no improvement after 8 weeks at an adequate dose, either switch to another antidepressant or augment with another agent. And when we say adequate dose, we want to know that we've sort of moved the dose up to the maximum potentially efficacious medication without any side effects. And so again, getting to that adequate dose can take some time, especially because, we're tending to wait several weeks before we reevaluate symptoms. And one last point is just to say that just across studies, SSRIs have generally shown better benefit for anxiety disorders rather than depression, especially in younger children. And that may be for a number of reasons, but that doesn't mean that they are not useful. It's just important to note that, um, just in terms of the studies, that it seems to show greater efficacy in anxiety disorders than a depressive disorder. And that may be in part due to sort of the heterogeneity of depression, the different presentations. It's not completely understood why that discrepancy exists. A couple of studies for you to think about and look at, but these are the big ones that have provided us with a lot of great information. So there was the TAD study, and the TAD studies basically told us kind of what we already knew, which was that a combination of therapy, in this case cognitive behavioral therapy, and fluoxetine was superior to either therapy alone, medication alone, or placebo. And so when we're what I take this to mean is that when I'm seeing somebody and I think they need a medication, I'm always, always, always talking about therapy as an adjunct to the medication in order to really support that child. Um, the Tordia study demonstrated that CBT improved the response. Um, and that substance use, anhedonic symptoms, and then family conflict all predicted poorer response. So I think for me, what this really highlights is the need to be thinking about other underlying causes that may undermine the efficacy of the medication or intervention that you're going to use, like a substance use issue, and then contextual and environmental factors that are actually really important to be changing. SSRIs can be helpful, but if some of this is arising from factors within the family context, we really need to be thinking about how we help people with that. I won't talk about the other trials. We'll skip this slide. So I want to just highlight something for everybody to take a look at called the GLAD PC Toolkit. This is guidelines for adolescent depression in primary care. And really this sort of the kind of progression here is we screen our kids, right? We talked about those screeners for depression. We've got the PHQ-9 and the short moods and feelings questionnaire. We really sort of gather our information to provide a diagnosis. It includes ruling out those things that we maybe think are medical or organic causes for having depressive symptoms. We start with our treatment. We try to achieve that response and achieve remission. Hopefully we get to recovery, and then in that point, we're managing once we retrieve recovery, we're kind of managing for a period of time before we consider all of the factors and make a decision with the patient about whether or not we continue in the medication or we decide to trial off of the medication after they've had a really good period, at least a year, of remission from their depressive episode. And unfortunately, within the context of depression in particular, recurrences can happen. And so we really want to be accounting for that when we're thinking about the long-term trajectory of the SSRI treatment in our kids. Um, so just a little bit about symptom severity. How do we sort of grade this? Because I think symptom severity can also often help us in making a decision when we have a kid who's showing up with us. And I can envision a scenario where maybe we have a kid who we don't know. He or she is new to us, and we're thinking that they may need a medication. Using the symptom severity guide could be helpful. And so mild, you can see at the bottom, the PHQ-9 can be particularly useful. A score of 5 to 9 corresponds to mild. And we can also use level of impairment, which I also often use to make a decision about where somebody falls on the spectrum. And 0 to 1 areas impaired kind of in a weekly way. So that these are areas like functioning within school, taking care of your body, going to school, eating and drinking, engaging with family, participating in activities, that kind of stuff. For moderate, right, 1 to 2 areas are impaired daily. Maybe they have some kind of co-occurring condition. They have a history of suicidal self-ideation, and maybe their PHQ-9 is from a range of 10 to 19. And then really severe is when you've got PHQ-9s greater than 19, and you've got 2 or more areas of impairment or 2 or more co-occurring conditions within that kid. And we put on the side clinical judgment on the edge here because at the end of the day, our clinical judgment also informs what we make decisions about. But again, these symptom buckets or categories can be helpful for helping us to think about where somebody falls and when I should initiate an SSRI. I've sort of already said this, but remember, we're always thinking about the biological, psychological, and social factors, as well as cultural factors that all sort of interact that lead us to either decide to start or not start a medication in someone. And these are all really important things to think about. So how do you get started? Well, if you've got a mild depression, we sort of suggest just an active monitoring kind of stance for 6 to 8 weeks. When we say active monitoring, I think one of the really, really critical pieces here is to set and monitor treatment goals. So what that means is we're not going to just disappear for 6 to 8 weeks and not do anything. We're going to talk to our kids about getting out, behavioral activation, participating in activities that they like to do. Maybe families are coming together to work on things. And then we're also doing safety planning with them as well. But it seems reasonable in a mild depression without any acute safety concerns to kind of do that active monitoring piece. If somebody falls into that moderate to severe, maybe because they have a PHQ-9 that reaches that threshold, right? Greater than 9, greater than 10. And they are maybe not functioning that well. Maybe they're not participating in activities anymore. Then we want to think about medication as well as psychotherapy at the same time. Because remember, I mentioned one of the major studies really demonstrated superior efficacy for both for a combined treatment of psychotherapy and medication at the same time. And so again, moderate to severe might warrant that immediate treatment piece. What are some evidence-based therapies for depression? Well, that includes CBT and IPT. And I would recommend that if you're referring somebody to something to give your patient some information about the kinds of therapies that they may be looking for or asking about, and trying to find somebody who could engage in some of these particular kinds of evidence-based therapies that really do tend to be time limited. Because the other thing we're always thinking about is how do we get kids moving back to their sort of normal state and just being kids, right? And so CBT can be, again, time limited in many cases and be thinking about adding that onto your medication. Um, I won't mention this, but for anxiety, right, we really want to assess and screen, diagnose, make decisions about severity. Either it's mild or it's moderate or severe, and using your GAD-7 can help you make a decision about that. And same kind of um, the same sort of um, algorithm really kind of applies here, right? If you are in that mild piece, thinking about education, lifestyle modifications, maybe adding in a bit of meditation, there are lots of interesting groups and apps and things like that. And you may try that for a few weeks to see if the child's own inner resilience factors can sort of come to light and help them manage the anxiety that they're experiencing. However, if they are into that moderate to severe condition, either because their GAD-7 is really high or because they're functioning in a everyday kind of way is really impaired, then you really want to think about adding on a CBT therapy. The reason we say start with CBT therapy is that CBT is actually really, really effective for an anxiety disorder. And so you might try a trial of a couple of weeks of CBT, again, assuming that they are not completely, that their anxiety is not so debilitating, right? That they could actually engage in that therapeutic intervention. And then if they're, if that after that 12 weeks you don't see a response to CBT, then you might consider medication. Again, clinical judgment sort of kind of really applies here. And so if that kid really is not engaging, you may consider an SSRI at that point. And again, also refer out to your for emergent psychiatric treatment if they are suicidal, if they are psychotic, if there are lots of co-occurring issues, or if they've actually tried SSRIs in the past and have failed two already, right? Sending them to specialty care will be helpful in kind of managing the situation. But in these sort of more run-of-the-mill situations, be thinking about this as kind of the algorithm, mild versus moderate/severe, and that being a decision about what you want to do. There are lots of great resources on the CalMap website that are patient-facing that you might offer in terms of treatment of anxiety, pharmacological treatment of anxiety. So, we've sort of talked about this, but I think it's worth you know, repeating, which is, when do you prescribe in primary care? Uncomplicated mild anxiety that progresses to moderate anxiety. So let's say you've seen that kid, they were mild, you tried to implement those wellness and kind of getting the parents to support that child, and it still progressed to moderate, then you might think about that SSRI, especially if they're, again, not functioning in an appropriate way. As I said, significant impairment. I can't go to school. I can't get on the bus to go to school. I can't do my homework, right? Things like that. I'm too afraid to eat. Um, let's say they went through their therapy and it still didn't work. If they had a failed or partial response, that is another indication to start prescribing. Um, our parents and our families always have to buy in, right? And so once we talk to them about medication risks and benefits, want to then decide with them about whether or not they would like to try a medication. The other piece is about our level of comfort. Do I know this person? Like, is the family one that is actually capable of monitoring the medication? If it's a family that's very disorganized, or maybe like they can't quite keep track, it might not be the right time for a prescription, and that has to be an internal choice about how you know. And then the ability to consult and collaborate. We never have to worry alone. That was something somebody taught me a long time ago. And so what's wonderful is you now have the Cal Map line, and so you can always call us to discuss about a particular case and the specifics of that case. Um, we've sort of already talked about MDD severity, so I won't say it again. But here is a table that I find useful, that I actually still use, that lists all of the sort of common SSRIs with their common names, the formulations that they come in, which is really important, the starting dose, the typical effective doses, and then the maximum doses. And then I just want to make one point here, which is about FDA approval. There are lots of things that don't necessarily have an FDA approval or designation for a particular condition, um, for a particular condition. And that doesn't mean that they aren't necessarily effective or used. We just might have to use them off-label. Um, but you can see there are some general guidelines. So Prozac, for example, is approved in MDD for kids greater than or equal to 8 years old. Escitalopram greater than or equal to 12 years old. You can see sertraline, for example, does not have an MDD approval, but we do use it, right? Because again, we talked about the efficacy of these things being somewhat similar. In general, though, with younger kids, we do tend towards Prozac as a first choice. And I have to say, anecdotally, it has been a good choice for most kids. Um, and so this will be available, and so it's just a nice thing to have as a resource, right? As a reference guide for yourself. Here's another great one that I actually still use, which is kind of the timing and the effect on energies and some other kind of like high-level pearls. So Prozac we like because it's the longest half-life, which means if a kid misses a dose, which honestly happens a lot, right? People are running around, it's hard to keep track. Non-adherence is an issue. And so Prozac actually is really great. And I tend to pick this as my first choice for most kids, barring barring some other specific features of that case. But it can be more activating in the morning, tend to dose it in the morning because of that activation. Great for people with medication adherence issues. And it's the only SSRI that really you can just stop without a taper at the end because it sort of auto tapers because of that long half-life. Sertraline can be great. It tends to be slightly more sedating because it has a sort of mild dopamine blockage effect. I tend to pick this for kids who maybe have a more anxious presentation. Luvox is one that we don't use very much in the United States. I won't talk about it. Lexapro, again, maybe neutral activating or sedating. I think one of the things that is useful about Lexapro, as I mentioned earlier, is one, it has less drug interaction. So if you've got a medically complex kid, this is a great choice. And typically has less sexual side effects. And citalopram, same thing, the least drug-drug interactions. Paxil is one that we don't see prescribed very often. One, because it has the highest risk of weight gain and has a very sedating side effect. And so really I would avoid and not, we include it here because it is an SSRI, but it's not one that I routinely use in clinical practice. And it does have a high level of drug-drug interactions for our medically complex kids. I've had kids who have lots of conditions like epilepsy and other things like that. I actually tend towards Lexapro when I'm seeing those kids. Before we start a medication, want to educate people, get consent from the guardian, and then get the youth to be on board. Got to have a safety plan, and then also be thinking about what's our timing? How are we going to see each other now that we're starting this journey of like doing a medication together? Um, So I'll just say this about consent, right? We want to let people know about the potential side effects. My general spiel is there are lots of potential side effects. Some come on earlier, some come on later, but most are transient. Things like GI disturbances, some sleep difficulties, and some activation, which we'll talk about in a minute. And then we're going to talk about this again. We also have to talk to people about the black box warning and let parents know and help let them make a decision about how they want to go about doing this, but always reminding people that while there are always sort of risks associated, there's also great risk from undertreating or not treating an underlying depression or anxiety disorder. In the first month, we want to kind of, if you can, monitor weekly. Doesn't have to be an in-person check-in, but could be a quick phone call or a message from the parent who's just checking in. Always start low, and you can increase in 2 to 4 weeks if there are no side effects. In that second month, maybe you're thinking about every other week because things are starting to work. And then within that 3 to 6 weeks, you're going to see some kind of effect. And then after that second month, then you can sort of go to monitoring monthly if you can. And then if they've been on it for 1 year of treatment, then you can sort of go to every 6 months. And again, you get to choose the pace of how you see people. And so it also depends on your practice and your level of comfort. And we can get kind of creative about how we check in, especially if you have a great partner, parent who's a partner, or a great caregiver or guardian who's a partner. They can kind of be able to give you feedback about what might be happening in the moment so that you can sort of feel like you're monitoring in a way that doesn't take up too much of your time. I mentioned some of the side effects: GI distress, headache, appetite changes, sedation, sleep disturbance, diaphoresis, sexual side effects. We'll talk a little bit about activation and then platelet dysfunction. Most of these things really do um, disappear within a couple of weeks. And I usually tell people that I'm starting slow. I'm starting low and going slow, and set the expectation that, I'm really thinking about the potential for side effects and wanting to limit that. And I do think that setting that expectation is actually really, really helpful for people. I can't say with 100% certainty, but I think it potentially reduces the incidence of emergent side effects from SSRI medications. This is not it's a big deal to start something, I think, for kids. And so couching um the setting the expectation of side effects and that these things are transient really does help people feel much more settled. I do want to talk about one really big side effect that we should always be thinking about, which is serotonin syndrome, and differentiating that from neuroleptic malignant syndrome. And so serotonin syndrome is this kind of uncomfortable flu-like kind of experience. It tends to happen within 24 hours. You get this hyperreactivity um, and hyperreflexia. You get clonus, agitation, fever. And so it can look very, very scary. That's different than neuroleptic malignant syndrome, which occurs at days to weeks after, and generally occurs with things like antipsychotics. Serotonin syndrome, is something we have to make people aware of, but recognize that it's very uncommon, and that really is more of an issue when you're taking another highly serotonergic drug. Really, the classic one is like a tramadol or something, which is not necessarily, or hopefully not happening in our kids, but something to just consider. But it's not super common, but something we should remind people about. And then just remind them that it's not really a huge concern unless you're taking really high doses or other really highly serotonergic drugs at the same time. Um, the black box warning and talking about this. So in 2004, the FDA introduced this black box warning about the increased risk of suicidal thoughts and behaviors in young people up to age 25. I'm going to make a couple of very key points here. Is that one, the actual rate of suicidal ideation or self-injurious behavior wasn't necessarily like much higher compared to placebo. So 3.8% of patients on SSRIs versus 2.2 on placebo, which could argue that there's some component here of the underlying depressive disorder. The other really big thing to point out and to note to people is that there weren't any actual increase in suicides in those studies. Suicidal thoughts, yes, but not increase in suicides. And then when they looked at the individual studies, there weren't any worsening or new suicidal ideation reported in 17 or 20 out of 24 of the studies. But really, the thing that we want to tell people is that, listen, there is a black box warning. The adverse event rate is low, but the risk is highest in the first 9 days of treatment and with higher than usual starting doses. Let's make sure that we're keeping track of this so that it hasn't changed from where it has been or developed or progressed in some way. And that's really the critical issue, making sure that if it was present, that it's not ramping up in a really high way, or that if it wasn't present, that it's just developed in a significant or severe kind of way. Um, in some cases, the risk of SI may actually be related to something called activation. And that's the thing that happens in patient that I call ants in the pants when I talk to kids about it. And so it's really restlessness, agitation, irritability. And it can occur in the first 1 to 3 months of the treatment. If it's mild, it usually goes away. Um, and and so we just want to be monitoring for that at that moment. Um, At the bottom here is the SSRI benefit to suicidal risk comparison. And so, you can see the number needed to treat and the number needed to harm for depression and for OCD and for anxiety is pretty significantly different. So just all of this to say that the suicide risk is there and there is a black box warning, but it may be slightly more it's maybe slightly large, it maybe feel like slightly larger than it is, but we always want to be looking and monitoring. And really in those first 9 days, that is when the greatest risk is present. I'm going to skip some of this. Some factors that predict suicidality within 6 weeks. So our female patients, female sex, the presence of underlying depression. And again, as I said, how much of this is the SSRI and how much of this is sort of the natural history of depression. And then factors that we sort of already kind of knew, which is if you've got a kid with a history of previous suicidality or previous self-harm, the risk for suicidality within 6 weeks of SSRI initiation is higher. And so these are factors that I'm thinking about when I'm making a plan about who I need to see more frequently, when I need to check in with people, who who am I more or less concerned about? And again, this can help you in making decisions about how you do that monitoring schedule. And I use this, in my own practice to kind of help me think um, about how to manage this kind of thing. I won't talk about the mechanisms, but this is here, and there's a paper listed here that talks about the potential mechanisms. We've talked about activation, but in terms of the management piece, because remember we said it presents in the first 1 to 3 months, assess adherence. So make sure the person's actually taking the medication. Is this activation or is this because they're not adherent to the dose? You can decrease the dose, you can switch to something else, or you can stop altogether. If someone has that ants in the pants, akathisia, restlessness kind of experience, you could think about a beta blocker. But again, I think assessing adherence and potentially trying a dose decrease if the patient can tolerate it without any worsening of their depressive symptoms, usually a great way to go. Let's talk really quickly about behavioral activation versus bipolar switching, because I think this is something that comes up quite a bit. So we've talked about that activation piece, right? It's uncomfortable, I can't sit still, and it can sometimes make providers concerned that have I uncovered some kind of bipolar diathesis in this situation? Is this a situation where I gave the SSRI and now there was maybe some family history? But there are some features that differentiate behavioral activation versus bipolar switching. And so you can sort of breathe a little bit easier if this is sort of presenting in this particular way. And so activation really tends to present in the days to weeks after a dose increase. But the critical piece here is that mood does not change. They may show this like nervousness and irritability, but it's not necessarily associated with the mood change. And just because someone has activation, it does not mean that they're going to develop bipolar or disorder or that they have a bipolar disorder. In contrast, bipolar switching occurs later in treatment, and it may not abate with a discontinuation of the medication. And really, again, critical piece is mood changes are present. Really much, much, much less than common than activation. Bipolar presentations in a pediatric population is not very common. But it is something we always have to think about, especially in light of a family history. Um, but in that case, if you are concerned, I would recommend referral for psych evaluation, which requires really a different kind of medication plan. Okay. Talking with parents. A couple of things that have come up. Will this medication make my kid a zombie? The answer is SSRIs don't change somebody's personality. At some high doses, in some cases, you can have a flattening of affect or a loss of emotions. And in that case, lowering the dose, augmenting with another medication, or switching can be helpful. But it doesn't make them a different person. Um, would my child be better off not taking meds? After the black box warning, really PCPs and lots of people felt less comfortable prescribing medications. Since that time, and in that time, child depression, suicide rates um, also increased right after. And so really what I tell people is yes, I recognize that meds are scary and it can feel kind of uncomfortable, but depression is worth treating. It comes along with both risk to life in terms of suicidality, but also we're setting our kids up for the development of chronic diseases and shorter lifespans when we don't treat depression adequately. And I usually let the conversation happen over time, right? They may not be ready right now at this moment in this visit, but maybe they're ready at the next visit. If you're on a medication, one thing that we talk about is cross tapering, and this is the art of medication and psychopharmacology and not the science. You could substitute the new SSRI at the same dose, the same equivalent dose, or you could start a new SSRI at a lower dose while also lowering the current dose so that they kind of cross over. And in the case of Prozac, because it tends to auto taper, you could DC the Prozac for a week and then start the new SSRI at a lower equivalent dose to see if you could get good coverage without too much. But again, this is not a science, this is an art, and we're always happy to have a conversation with you about the optimal way to do this, especially in the context of particular factors for a patient that you may have. This will be available, but this is something that I still use. So on the right-hand side, left-hand side shows the approximate half-life in days, but then the right-hand side shows the equivalent doses of medications of the SSRIs. And so I use this to help me decide where am I gonna how am I gonna cross taper so that I don't, if I had an effective dose, but I was getting side effects in a kid, how do I get the dose back up to that without having a gap or a drop in their levels. And then lastly, let's just talk about SSRI discontinuation. That looks also like a kind of flu-like symptoms, insomnia, nausea, sensory disturbances, hyperarousal. It happens in maybe about 20% of kids. And really the strategy here is to do a gradual taper. If you have a family that says, I'm really sensitive to medications, maybe you have a kid that's particularly anxious about medications and particularly um, aware of internal bodily sensations, then think about doing a really, really slow titration, down titration, really decreasing by, even 25% of the dose that you had the week before. And think about using liquid formulations if you need to get like, sort of very fine detail or sort of incremental changes in dose, right? Lots of the medications, as you saw in that table, come in a liquid formulation. And so I think that that can also be a useful tool for us as well. So I want to make sure that we have time for questions, and so I will stop there. And hopefully we've answered some of your initial burning questions. But if there are more burning questions, that's what we're here to do. And
Thank you
I'll
so
stop
much.
sharing.
Thank you so much for this great talk. And as we're kind of going through this Q&A, if our staff could go ahead and pop up our check-in QR code for people who need to get that. First question. Seeing a lot of anxiety and panic attacks, especially in younger men after smoking marijuana. How long can this last? And when should one consider treatment?
That's a good one. So it's really interesting. I haven't seen any like literature about how long it can last necessarily. I can imagine though, right, that there is a rebound anxiety, especially if you've been kind of in that sort of depressed sort of state with marijuana for quite some time. When do you consider treatment? Well, I think that means what kind of treatment are you thinking about, right? And for me in this particular moment, uh we talked about kind of thinking about medical or organic causes. For me, the substance abuse piece rises to the top here. And so getting people kind of through that substance abuse piece, I think will be really critical. Potentially referring out to a psychiatrist who has some experience with substance abuse, who can help with that, with the coming off of the marijuana, because there are some potential pharmacological strategies there. But I would refer to somebody who has some substance abuse or addiction treatment kind of experience there.
Wonderful. Another participant knows that there are few CBT providers available, especially those who are available after school. Wait lists can be really long. What's your opinion of starting medication prior to CBT if access to therapy is just really restricted or months out?
Yep. And so I think that this is a great question, and it totally it totally I feel you. And we all are feeling this right now. And so one thing I would sort of say is, again, we talked about these kind of these algorithms being general guidelines, but our clinical judgment and the environmental context in which we all live always has to play a role. And so something is always better than nothing. I would keep working to try to get them connected, but if you have this sense that that this kid is really in a bad way and can't get access, we want to reduce that anxiety and reduce the consequences of that anxiety um, sooner rather than later. And then, be thinking about I know we talked a lot about CBT, but are there other things that we could do? The CalMap website has lots of resources that are patient-facing, videos, things that we can do. And I just want to put a plug in here really quickly, which is uh, we have to get parents to hold the weight for us a little bit too. So getting them to work with their kids, even if they don't have a therapist, getting some workbooks and things like that, and getting parents involved is gonna be really, really critical.
Wonderful. Um, I'm going to shift on to some SSRI directly related questions here. So many families stop treatment before 6 weeks, often due to a lack of follow-up, and especially if providers aren't available for that like cadence of follow-up in primary care, or a family simply just can't follow up that often. Um, what's known about payment availability for online follow-up in these cases, and personal experience is great here too.
Interesting. I guess maybe I don't know if the person could clarify what they mean by payment, or maybe you could clarify what you mean by payment.
Maybe for like telehealth or like e-visits, these kinds of shorter ways of
Oh,
touch points and some follow-up so that people don't just stop when they encounter side effects, because it is a common issue.
yeah. That is a good question. I'm sorry to say I don't have an answer for that. I don't know
Yeah.
if you have an answer on the payment side, or like getting reimbursed for like a quick, a short visit.
I have mostly not run into too many problems with telehealth visits still. And there has been a tremendous amount of professional society advocacy in maintaining payment for telehealth visits, even like with the end of like the public health emergency over COVID and all that. So far, no problems there. E-visits, it's a little bit up or down, and I've gotten some pushback from families because they're getting charged for like e-visits, like where they put in questions to the patient portal and you're answering. And if you charge for that time, insurance doesn't always cover that, but I still end up doing it just so people understand that this is provider time and this is a clinical service, and we need to start getting payers to pay for that. But it's a good question, and I feel like all of these options need to be made available to us because we don't always have like the in-person like appointment availability, especially as we're starting and titrating these meds. Um, so another question. Given that SSRIs can cause disinhibition, if you see that side effect in a patient, is it still okay to try another SSRI, or do we have to go to a different class of medication?
Yeah, so I think the person's asking, the disinhibition, that kind of uh the impulsiveness, and it may not, and is that a indicative of a bipolar diathesis? And I wouldn't, not necessarily. And what I would say is that, one trial of one medication giving you a side effect doesn't predict the same situation in another SSRI. So in my own practice, right, I don't throw anything out because I don't have a ton of options. And so just because one thing gave me something that was concerning, I'm not necessarily going there. Now, if I did a second trial, right, and I'm still seeing something, two pieces of information is enough to make a conclusion, or at least a tentative conclusion about something being a little concerning. And then I'm thinking refer for like more evaluate or deeper evaluation for for an underlying bipolar diathesis.
Fantastic, thank you for that. And please comment on whether you feel homeschooling is appropriate for kids who are acutely anxious and feeling unable to go to school.
So this is a great and complicated question. And so, when we treat when we treat kids with anxiety, so I've had lots of kids like this. The kid who has social anxiety, who has school refusal, right? And we're so stressed out because we don't want them to fall behind. But the question with anxiety, right, is are we helping them overcome that anxiety and deal with the issue if um we just take away the stressor, right? And really, my goal with this is always to help the child manage the stressor, or learn to manage the stressor, rather than removing the stressor from their environment, because there will be a time where we can't do that for particular stressors. And so I think, so the question there is, how do you manage that? Well, in the beginning part of that treatment, you may have difficulty getting them out into school, right? A graded kind of intervention in that sense, combined with SSRIs, right? Like going to school for part of the day or for one period a day, right? But never saying, okay, we're just going to get rid of it altogether, because our goal, we have to have in mind, our long-term goal is having this kid go back to what life looks like when they didn't have the anxiety disorder.
This is so important not to let kids keep on avoiding their anxiety triggers. And thank you so much for making it. I wanted to point out a couple of resources that I know about, going back to an early question about this, the lack of availability of CBT in many communities. And I am not associated with any of these resources, and I'm not getting royalties for any of them. But I do sometimes refer people here. One is actually a free resource. It's called Saluna. And I might ask for one of our staff to drop the link for Saluna into our chat. It's a free app for teens ages 13 and up that's funded by Department of Healthcare Services here in California. They can talk not to therapists, but to coaches. So they're trained behavioral coaches who are nice people and who have gotten some training and some CBT type principles, who are just available there to like talk with youth. And for that kind of like support and some psychoeducation on what you could do for anxiety and depression, it's immediate and it's free. So you should know about Saluna. Um, then there is also Project Yes, which is basically online self-paced CBT training for kids. So for teens, like it's not the same as having a therapist, but they get introduced to a lot of the same skills that they would learn in CBT through Project Yes. There's also Project Empower from the same Slider Lab for like anxiety in school age kids. Um, and then, yeah, okay, there's another question that came through that we should definitely talk about. So this is clearly a common situation. What do you say to parents who homeschool for this reason, right? Kid is just so anxious, they won't go. So parents are homeschooling.
Yeah. So I want to be very clear, right? I always want to support a parent's decision and choice that's like specific to their family about like how they want to educate their kids. So if that's homeschooling, that's homeschooling. The question here though is like homeschooling for that reason, right? If they're making a shift or a change from what their life normally looks like and kind of reorganizing everything because of the anxiety, that I think is problematic. The other piece though is that if for whatever reason you do need to homeschool or that feels like the next best step for them, then to be thinking about socialization, right? Because there are lots of kids who get homeschooled who have socialization in other ways, right? And so if you decide to go that route because it's what's right for your family, but the kid is socially anxious, then we have to be thinking about how we get that kid social engagement in other scenarios, right, to deal with that issue.
Absolutely. Well, thank you so much for the talk today. Thank you to all our audience for the participation and for the great questions that are here. Um, Quick reminder that our next webinar is coming up on November 21st. This will be on motivational interviewing featuring Dr. Jessica Kaiser. We hope you can join us then. Meanwhile, hope everyone has a great week and we hope to see you then. Take care.